Great, welcome back, everyone. It's 1:20. Sorry, we are late. Every meeting today. We have legislative council with us again this afternoon, and we're switching to H 721 and relating to expanding access to Medicaid and Dr. Dinosaur. So where we left off was we were having Jen make updates, and so she's ready to walk us through the latest, which is
Is it on here, Jen?
yes.
Yes.
It's 2.3.
2.3.
And I think we have.
Yeah, 2.3.
All right.
All right, good afternoon, Jen Carmen from the Office of Legislative Counsel. So we are looking at the latest on H 721 and act relating to expanding access to Medicaid and Dr. Dinosaur. As usual, the changes are all highlighted. There is one that's highlighted in green because there isn't actually a change, but I think there maybe is supposed to be, and so I'm flagging it. It's the money. Been steady, just reviewing that for Nolan. Spoiler alert. All right, so we go through, back up here a little bit. All right, so no changes until section 3, which starts on page 6.
I'm having a moment. Is that on today's thing?
Yes, you may have to refresh because it was
Is it draft 2.3?
2.3, yep.
I just might want to know, we went from 24 pages to 15, so.
Yes, and maybe even get a little bit shorter once you take the bold and struck language out.
Exactly. All right.
All right, so section 3 is the Agency of Human Services technical analysis. And so just framing where we are. And the changes start in the technical analysis relating to provider reimbursement rates. And so first, it looks like 2 things are coming out, but they're actually just getting moved because they're having kind of a later date. So C and G are getting moved. And I've relettered things so it flows, but not if you look at what's crossed out. So at the moment, what is actually changed in this piece is the estimate of the cost to the state by provider type. If providers were reimbursed at various percentages of the Medicare rates, and I've added 200% in addition to 125, 145, and 160. And then you'll see these other 2 subdivisions show up later. They have a later effective date or a later report due date. They both have to do with commercial health insurance. DVA has asked for more time to work on those. So even though they look struck, I copied and pasted them down in another page or 2. Also, there was a request for the piece of the analysis that looks at an estimate of the costs of including comprehensive prenatal labor and delivery, postpartum, and psychiatric services under the primary care rate. If there's going to continue to be a rate differential between primary and specialty care services under the RBRVS fee schedule, this would add other reproductive health care services in addition to prenatal labor and delivery and postpartum. Then the language you see struck on page 9 really is struck. So this does not show up somewhere else. And what had been proposed as J and K would come out. J relates to payment methodologies for FQHCs, and it sounds like there's some ongoing work or negotiations happening between DVA and the FQHCs, and that DVA has asked to continue to pursue on the track that they are pursuing that on, and not as a part of this analysis. And the dental review of their dental services, I think, is really, DVA pointed out, is kind of captured in the definition of provider type. We include dental services in there, so they don't need to be spelled out for their own special treatment, and evaluating progress toward achieving recommendations from a working group report on dental access really seemed, as DVA pointed out, a little beyond the scope of what the bill is looking for. So that
We're
may be
already doing
something.
that from the budget from last year. We're getting
Okay.
Yeah.
Great. So a couple changes to the definition of provider type. First, specifying that means the designated and specialized service agencies as a provider type, and each category of healthcare provider, and the way it had said was each category of healthcare provider for which DIVA has a reimbursement methodology, and then it listed a bunch of services. So now I have changed it to say category of healthcare provider that provides services for which DIVA has a reimbursement methodology, and then we have the list of services, just so it makes a little more sense. All right, and then at the top of page 11, this is where I've highlighted in green, just because it's not new language, but the current appropriation amount is 350,000 between state and federal funds. DIVA had mentioned they may be asking for a different amount, but I don't know what the breakdown is in state and federal funds or if they've settled on the amount. So highlighted here so we don't forget about it.
So, yeah, so we can come back to this.
All right, then I've split the report date into two subdivisions. So we have on or before January 15th of 2025, AHS would submit the technical analysis as we've seen in previous drafts. And then I broke out just for those two that DIVA asked for more time on or before January 15th, 2026, the agency would provide to the same committees, and here's that language that had been C and G above. So an analysis of how current Vermont Medicaid rates compare to rates paid to Vermont providers by provider type under Medicare and average commercial health insurance fee schedules, and an estimate of the costs to the state and the advantages and disadvantages of benchmarking rates for RBRVS equivalent professional services based on average commercial health insurance rates paid to Vermont providers rather than the Medicare fee for service physicians fee schedule. And as I'm looking at this, we talked about commercial. I just took this whole piece out. Do you want to split up and have Medicare reported earlier in 2025 and commercial reported in
Yeah, I
2026?
think it's just the commercial that's
Since you're
26.
since you're asking for percentages of
Yeah.
Medicare. Okay. So I'm going to need to put this one back in and just partly back it. So we're going to put this in another color. So I remember that I'm not done.
That's okay, but it's probably not Jen.
What are you gonna do with that, Jen?
So I'm going to split this 2A in half. I'm going to put the piece about reporting on how Vermont Medicaid rates compare to rates paid to providers under Medicare back in under the 2025 timeline for the report, and keep just how they compare to commercial insurance rates under the 2026 report. All right. That is that section. I have to scroll through. Yes, that is it.
So, I can just give some background on the reason we're moving the commercial average, that those two sections, to a different 2026. The only way we can get to that data is through VECRS. And so DIVA will need more time because of that to do that section. So I want to give them that time to have a thorough analysis. Therefore, I asked Jen to add in the first section, which is where we're getting a report back in 25, 200% to Medicare, so that we don't have to wait to 2026 if the people sitting in this chair don't want to, and 200% might be a little bit closer to commercial average rates than the others. So I just wanted to put another piece in there to go a little bit higher to come back in 2025. And then the commercial averages analysis will come back in 26. All right, questions for Jen on the language?
My only question is, will this information come back to the people sitting in this room in the next biennium?
Yes.
Yes, so that's the thought.
Yes, it comes back in January of 25 and then another piece in January 26. And
Okay, so
yes,
that
the
will be
elections in
same
November.
people,
So
yeah, the same people for
yeah, so the
both.
same people. Yes, I see what you're saying. Yes, it will be the same House Healthcare Committee members receiving the 25 and 26 reports.
As we're looking at language, I just wanted, since we haven't actually looked at the full bill in a while, I just also want to remind people after the technical analysis is the section about DEVA coming back to us on global commitment investments and how they're working. And then there's the section on Medicaid covered services. So that's where we had really changed this section for my intent as the sponsor of the bill was to make the process more transparent of what Medicaid looks at when they determine what services may or may not be covered. And after working with Medicaid, we came up with section 5 is a report out they will do. The section 6, which we'll have to come back to, is the Medicare Savings Program. And then section 7 is going after state plan amendment if it's needed. Did we lose part about, I know what I'm trying to say and I can't think of it. The public option for small businesses.
No, that is in the report.
It is, okay.
Yep. So we have an assessment of how other states' public option and Medicaid buy-in programs set provider rates, but there's another one on that too, public. Examining the feasibility of creating a public option, at the top of page 10 or other, I think.
Yeah. Bottom of page 10.
Bottom of page 10? I've taken out some language. I'm working on them.
Okay.
What we'll call 3.1.
Did we lose? Oh. Did we lose the part about, possible premiums at various income levels? We were doing that.
What are really
We had sliding scale, cost sharing. We don't have premiums, but sliding scale cost sharing requirements.
Okay. So we didn't lose.
That's still in there.
That's still in there on what I show as page 7, number 6. So B6.
Other questions on the language before we just have a conversation? Okay, we're not good.
Please, okay. So,
Okay, thank you, Jen.
Sure. We'll keep.
So, I'm sorry, the only other thing I will add is DEVA has said 450,000. So if you can do the split and let Jen know. Okay, so for what's been changed. Oh, Jen, I did have one other question, sorry. So we took out the language on page 9 about the alternative payment methodology for FQHCs.
Yeah.
But on the list of provider types, FQHC is included in there,
Yes.
correct? Just want to make sure that's clear to everyone.
That's a good.
They would still
Yes,
be,
they're still included as a provider type.
Okay.
It's provided by federally qualified health centers and rural health centers.
oh, right, that is actually in there. Okay, page 2. Okay, thoughts, comments, discussion, where is everyone? What's that?
Maybe, did I ask this question already? And I don't know if anyone can answer it, but the information in order to do an analysis, comparing rates to, Medicare and the average commercial health insurance, is that data even available? Is that in the VCARES?
So the average,
Proprietary rate.
so what, I was about to take it out, when one of the stakeholders reminded me that this was done in the Dr. D 2.0 study in 2000. Yeah. So it is available.
It's available.
Yeah.
Through VCARES, right?
For the average commercial.
Okay.
Yeah. We went back and forth and then DEVA finally said yes, that is, but then they would need more time for that piece. I agree. Where do people stand? Changes, additions? Adjustments? Not interested?
I'm okay with it.
What? Are we not talking about this yet? We can talk about that?
Oh.
Great.
I thought we were doing all the other language.
Nope, everything. It's wide, we're wide open.
I was just.
You wanna start?
Sure, I support the changes that we've talked about. I would like us to consider option one off of the expansion program for the investment that would get us so much for so many.
So this is the Medicare Savings Program, which is section 6.
Hardly second that.
Heartily third that.
Yay.
Right, so on the table,
What option is the current language right now?
It's two, and we want, I put out.
No, it's six.
Oh, that's even better.
okay. So let's plan on putting in option 1.
And remind me what.
We haven't heard from everybody.
190,
Well, we're gonna put it in and then we're gonna have a discussion.
225.
And then that, so can I just, I mean,
Yes.
that also, I think necessarily goes getting the lead farm, is that right?
The cost savings assume deep farm is phased out.
Space, I don't think.
Means it just can work through.
So-
That's the
so-
question.
So I
Yeah, so we don't need it right now, obviously, yeah,
Yes,
no.
there's some
So if you-
implementation questions.
Yeah, if you can connect with Stephanie, that would be really helpful. Today's only Wednesday, right?
Yes.
Okay, well, when she works on the language, we can have further discussion of what this all means.
But that means Swinby stays in. That means Swinby stays in.
Yes.
What did you say?
The clause over here, the Melody, the Quimby and the Slimby and the QI.
Oh,
And in some of the options, Slimby goes away, in this one it stays in. So just looking across that. For option one.
option one.
Yeah,
So I think option 1, we can discuss as a general, do we approve or not? Let's let legal counsel figure out how to put it in. Is that how? Okay. Okay, this is like the quietest this group has ever been.
We all had lunch, you're like.
I don't even know what to say. Go, Alan.
Maybe I don't understand this, but I'm voting no.
Okay,
I just think we've expanded Medicaid for everything. And it's probably gonna save us in the long run, but that hasn't been proven to me yet.
okay. Melissa?
Can I ask a clarifying question?
Yes.
To you? So are you saying no to like all the parts of the bill or just that Medicare savings?
The Medicare savings.
Okay. Sure.
Okay. Art? Nothing? Oh, I thought you raised your
Really
hand.
just like,
Okay,
whatever.
okay. So we're gonna have Jen work on the language and then we're gonna come back for a vote if there's no discussion.
that sounds good to me.
Record of action ready
Well,
to
we're not
go.
gonna vote today.
Oh, okay, it's still ready to go if we need it.
Yeah, thank
We're all
you.
ready to
No,
go.
we're not gonna vote today because we want to give Jen time to, or we could vote later depending on when Jen comes back to us. but-
Do we know the numbers that are gonna transition from Medicaid to?
No, so let's remind what we're doing here. So most of the bill is technical analysis.
Yes, and that's a
For
study.
$450,000, $50,000 of which only a percentage of it is general fund, one-time money, that will answer all those questions you have. And then when that study, technical analysis comes back, people sitting in this committee or health and welfare could choose or not to choose to do anything with it. But it will give us a detailed analysis of who would be coming over, what what we would have to increase so providers could be appropriately paid. What would the effect be on commercial insurers? Because we might be pulling people over from the qualified health plans. How many, individuals up to 26 that would continue to be covered? All of that stuff. It's kind of like, think about the child care bill, which I know didn't come through here. There was a lot of technical analysis that was done before the final bill was rolled out and voted on. So that's what that is. Medical savings program, if we put it in, option 1, would not take effect until 2026. We do know the people who would benefit from that program. And we do know the cost to the state, which is all that information on row 1. And appropriations could choose or not to choose to keep that in the bill or not keep that in the bill. And then the other pieces, there's no costs to any of them. Different things we want to get back from Devon.
So they're saying 15,000?
People.
Okay, if we go to the 190.
Yes.
Okay. The MSP enrollees, 15,000 for 43
I'm
months.
going to have Mike come to the table.
Okay, explain that to me, Mike.
So, hello again, Mike Fisher, healthcare advocate. So I said this once to the committee already. I know that DEVA gave it's right here too, gave an estimate of the total new MSP population for option 1 as 15,199. And if you've noticed, I've been walking around the building saying, no, actually, the right number is 19,217. And the confusing thing is both of us are right. They did not back out. Emma, you're gonna have to help me. They included a population of people who are already on a prescription drug program. That prescription drug program is not MSP. And so we included that number. At any rate, the total new population that will be getting the benefits of this program, I think the NBHC agree, is 19,217 estimated by DEVA.
Okay. Anything else for Mike before you?
But the other numbers stay the same?
Cost.
The cost number is, yes, is between 15 and 18, depending on federal funding.
Hate to do this. Can you remind, so option 1 keeps Slim B. Remind me right now why we have to keep Slim B. And because Slim B has the state match.
Right.
We need to get up to QI1. QI1 is all federal. Is there a reason that we have to keep, we can't just say Quimby this and then QI1?
So option 1 came about as a result of some conservatism from DEVA about fear of not having the full QI1 funding, and some concern about the QI1 range being 15 percentage points. That's how it came about. And I guess given the moment that we're in and all the work that's gone into this, I don't think it's the right moment to sort of go back and rerun new numbers and try and get them out of DEVA. I think we have an option in front of us that.
Theoretically,
Yes.
let's say that this passed and DEVA was tasked with going to CMS or CMMI and ones they go to. Could, if they found out that they didn't need to be as conservative and that theoretically, could we eliminate Slim B, which would take that, and wouldn't that?
I think it would take another act of the legislature. I think we would be.
They just unilaterally on their own couldn't say, oh, this is gonna save us a lot more money, and they're gonna let us do it, so.
My guess is they would have to follow the state statute, which you're setting.
It's not for Mike, so if there's.
Okay. Any other questions for Mike, and then we'll. Thanks, Mike. Melanie?
I appreciate the, how we worked through this bill and the fact that we are going to get more data before we make more changes. So I appreciate the edit in that. And I also like the fact of trying to do something for people that are on that cliff. And so I feel like we've struck a balance of being really responsible and trying to like get more numbers so that we can look, whoever's here in these seats can look for that and for changes, but also leaving something for people who are really suffering. So.
Well, I mean, I feel like I'm just repeating something I said before town meeting break, but depending on which number, if it's the 15 or the 18 million, it's a 5-to-1 or 6-to-1 return on investment split between the patients and the providers and into our economy. It seems like you couldn't get that kind of a deal, you know, the best stock market, operators. So I feel like it's, to me, that's why I'm so strongly in support of it.
I think I said, I promise I won't cry this time. I think I said also during the break, first of all, I absolutely appreciate the technical analysis piece. Every single time we talk about expanding Medicaid, it's nice to have the numbers, and I like that how forward-looking this is. So I really appreciate that piece, and I feel very strongly about the Medicare savings plan. This is a population that we've not touched. When we talk about Medicaid, it's a population that is forgotten when we talk about Medicaid. And frankly, I find it unconscionable that we say that some people deserve this. And then on your 65th birthday, we say you don't deserve it anymore. And I can't comprehend not leaving all this money, this federal money, untapped. And that we have a known dollar figure. I mean, we know exactly how much is going to go into somebody's pocket. And I can't see not doing every single thing that we can to help Vermonters. And it just seems like such a small, I know it's huge money, but it's such a small investment for a massive impact. It's just a huge impact. So I fully support this.
Thank you. Anyone else?
I just want to echo what you said, Alyssa, and I think Mike, somewhere in my brain, it's rattling around that it was going to put like $2,000 in people's pockets a month. Oh, annually. Okay. That's a lot of money for someone. They really need it. So that's what I'm thinking about. The individual in their home to pay bill. And I really feel it's important to support it for that reason.
Okay. Ellen?
If all that is true, that's fine. But common sense tells me that's not the way things operate down here. And I'm sorry, I sound cold and everything else, but I'm not so sure that's the right system we should be going at. I'm not sure. I don't know, but.
Because philosophically you don't agree with doing it, or you don't think mechanically it's
I
going?
don't think mechanically it's gonna work. And I'm probably wrong, and I hope a couple of years from now you say, told you so. I hope you could do that.
I'd love to be able to do that before tomorrow, but.
Okay. I'm gonna get the information.
Yeah, I think you're talking about Medicare savings program, not the technical analysis,
Oh, the technical, aspect, fine.
You're fine, okay.
Can I just say one thing about that? I mean, there are people on this program right now. And every single month, you get your social security check. And every single month, before you get your check, your Medicare Part B premium is removed from your check. And you get that final amount. And so what we're doing is we're expanding this program to 19,000 more people. And so 19,000 people will not have that money removed from their social security check. So mechanically, we know exactly what will happen. It's not an abstract.
Is this only for 65-year-olds?
Yes, because it's only when you go to Medicare.
Only go from.
So you're on Medicaid
So over.
till age 64 and 364 days.
So 19.
3 months before.
3 months, okay.
19,000 goes on implementation. What about the second year when those that are all 64 turn 65 or 60?
Well, yeah, it's.
So what's the ongoing cost? I know you're gonna say eventually there's enough money in there, but I find that hard to.
Mike, did you want to answer? No, okay.
I don't mean to be cold, but people turn 65 and then also people who are over 65 pass away. So, I mean,
19,000 of them?
You're a pretty old state.
We are pretty old, I agree with you.
And remember,
I know.
there are people that are going on it now, right? To the people who are going on it up to 100%. So every year,
Mhm.
we have that same type of churn. So I get where you're coming from, but it's kind of a known
I,
process. Like, this is one of the things that in our committee that
Thank
we
you.
don't know a lot of things in our committee sometimes.
that's what's scary.
But this one,
Thank you.
we know.
Thank you.
This one we know. Okay, so there is nothing else. We're gonna, we have this on our agenda tomorrow at 11, so I think we'll just let Ledge Council take their time and work through the language, and we'll come back to it tomorrow and go through the changes for option 1, and then have any discussion and take a vote. Sound good? Okay. So can we, since we have some time, I would love to talk a little bit about 741, which is what we just talked about before break, since we are running out of days here. If they're kind of like we did with the colonoscopy, is there a 621? Thank you. I knew I had that wrong. The colonoscopy one, we're coming back to as soon as I can get with Claire and scheduling to take a vote. And have Jen walk us through the changes we talked about yesterday. And then this morning, we talked about the breast imaging one for diagnostic purposes. We're waiting to hear back from Blue Cross Blue Shield. I really don't think we're going to have a cost estimate of premiums. I don't think they can provide that. So that is an unknown. It is, again, qualified health plans, only those who are getting mammograms or, and only if they don't have a high deductible plan. So it's a more narrow group than even our narrow group normally is. So anyway, just opening up for discussion on what people want to do, and so we can determine how to move forward. Alyssa. Anyone else that wants to go before Alyssa? I feel like she's always like, go ahead.
it's because it's like right in your
Right in my
line
view.
of sight. I'm supportive of the breast screening. I am concerned that when we receive numbers from the payers, that they will include true diagnostic imaging that is not related to a suspicion from screening mammogram. And so, I mean, I think that.
Because we're not sure
okay.
how we can
Yeah,
separate
so,
that.
so I'm not sure how that, okay, so like you go in for your mammogram, they're like, I'm not sure, come on in for an ultrasound or an MRI. Because we want to look a little bit further, and then you have that done, and that's the end of it. That's what we're talking about covering here. But that's testing that arrives as the result of a original screening exam. There are also people who have lots of other things going on, and the same procedure, say ultrasound of breast, is the same procedure code that would be used if you were coming in post mammogram just for another look-see clarification. And I'm concerned that when they come back to give us numbers, they're going to give us all breast ultrasound.
Because I don't know how they would.
And I don't, that's what I'm saying is
Separate it.
I don't know how they'd be
Right.
able to separate it. And what I'm saying is I don't want some huge number to get thrown at us when it would be really great if we could just get information from the payers on how much it costs to cover at 100% just the follow-ups from what was originally a screening mammogram. Yeah. Oh, well, I'm sorry.
Yeah, sorry.
So staring at you.
Yes.
So you're not talking about a group of people that have incidental findings from, let's say they have an X-ray because they're a smoker and oops, they don't find any lung nodules, but they find a breast mass.
It could be that, or it could be somebody who has a mass and, perhaps they've had a lumpectomy and then 6 months later they come in and they have an ultrasound and then a 1 year follow-up with an ultrasound or MRI.
But
What
I
I'm
think
saying
you're-
is it's the same procedure code that's used for all of them.
And I think your concern is if they come back with a number, the number is going to be higher
Yeah.
than what the impact would be for them,
Yeah,
is what you're trying to say.
that's what I'm trying to say.
And-
A diagnostic code.
Yeah.
Right, because there's no separation.
Because there's no
They
separation.
just don't know, I mean, nothing that they're coming back to deceive us, just that there's no way to tell if it's after a screening or if it's just, part of a regular.
So there isn't a separate screening versus diagnostic code?
Well, there's a screening modifier. But so in ultrasounds, I don't believe you can have an ultrasound with a diagnostic code, like a Z code, which is a screening code. I think that you would have to use some sort of diagnostic code, or you would have to put a modifier on it saying this is screening, but I'm not sure that's done consistently. Because if it was, it would probably be covered right now, and it's not.
Sounds like that's an issue.
So I think that these procedures are being coded as diagnostic because they have to be.
But I think
And I don't want conflated
numbers. to
numbers.
impact our-
Yeah,
Okay.
that's what I'm trying to say.
Makes sense.
Well, let me ask you, is there any way to put in the bill? Because I'm thinking that's an education thing. To do the right code. Is there can't do it because do they all have the same code?
I'm wondering if it's possible to put in the bill that these are covered as they relate to a screening.
It's the result of the screening?
If they're the result of a screening.
So I asked Sarah about that at the
Yeah.
meeting, because one of the co-sponsors of this bill, one of the things we were concerned about is that we've already done the work for when a mammogram comes back and the screening wasn't conclusive, and so now you need an ultrasound because of that dense tissue. We have that in the existing bill, in law. And so one of the things that is also sometimes needed is an MRI. And one of the things that has come up is that when you talk about the coding, they're being told at Blue Cross and Blue Shield, which is a number of people have spoken to us about outside of this committee, is that the coders are saying that even if they try to put it as like a preventative screening, it defaults to to diagnostic. And so one thing that Sarah mentioned just over here when we were talking is that we may be able to modify the existing language to just open it a little so that it would allow for that to happen, so that you could have, like the ultrasound is allowed now, you could have an MRI based on that. And so the language that she and Emily recommended was just it says in existing law, in addition, insurers shall provide coverage for screening by ultrasound for a patient for whom the result of a screening mammogram were inconclusive. They recommended looking at and talking to led to council about maybe opening that to include appropriate follow-up screening for inconclusive. So just open that and allow for that coding to happen. Which would still be a very small amount of MRIs, but if it is needed because of that screening, and it's still in that category of screening and prevention and not diagnostic, that it would allow for more clarity in just what you said. So that was their recommendation at the break.
And you're gonna talk to Jeff?
Yes, okay.
And that was my point, is that I support this bill if it's for screening purposes, expanding coverage of, with no cost sharing of these services, if it's screening purposes. I personally not, if it's all diagnostic.
Oh, right.
Could I ask a question on that? As opposed to what? As opposed to, wouldn't all diagnostic come from a screening or no?
No, not necessarily.
Really?
Yeah.
No.
You have symptoms.
Pardon me?
You have symptoms.
Right, but let's go back to what Mike said at the end, which was, right now, there's a big sign when I go to my gynecologist that says, if you tell us you have a problem, this is not a screening. Big sign, big sign.
Okay.
So I've never done this, but if I had a problem, I would probably say, I don't have a problem. I'm just here for my annual exam. And then that would be a screening. It would be covered with no cost share. The whole thing would be done. And then if something is found and they say, oh, you need to come back for, another test to see what it is, now there's cost sharing.
Okay.
This would eliminate that. So is that what you're against?
Well, I hate to use the word
Sorry,
against.
is that not what you're for?
If I'm. I go in for my annual mammogram. I'll go in late. I need to, it's reminding me today, I need to schedule one.
That could be a field trip.
Everybody.
So for Alyssa's, we could all see Alyssa's mammogram.
So if I go in for my annual mammogram, and then 6 months later, if I notice that I have like a lump or something, I'm gonna go to my doctor and she's gonna say, let's take a look.
Right.
That's not screening anymore. I'm having that done because because there's a suspicion that there's something.
But let's say, hold on. Let's say you're that woman and you feel that lump and you're like, I cannot afford a $45 and $80, $200 copay. So I am not going to the doctor.
But to Sarah's point, there are thousands of things that people have that they don't go to the doctor because they can't afford it.
Right.
And
I think it's great if we eliminate one of them. That's just my.
The second biggest.
there's a lot of
Exactly.
things that
But here's the problem.
I'm absolutely in favor of expanding this if it is related to a screening. I'm not in favor of just blanketly saying all imaging of breasts has no cost share.
Okay.
That's it.
But here's the problem with Lori's scenario. She goes in, there's a big sign, she has a problem, she doesn't tell anybody because she doesn't want the cost share. You can't do good medical work unless you know the person's history. 95% of diagnosis is based on history, and you can't direct the care without knowing what you're looking for a radiologist. Oh my God, this person has a nipple discharge on that side coming from here and it's green, bad. But if I don't know that, I'm a radiologist, I'm not gonna know what to look for in a really comprehensive and doing good medical care. So we don't want to avoid, we don't want Lori to say, I'm not getting a test, or I'm not gonna tell. That is not good care.
Art?
Well, I probably shouldn't say anything. No, I struggle with this, and I'm pretty much in favor of this, depending on what we hear about numbers, and
And we may not hear numbers, I just wanted.
Right,
We heard a little bit from the other.
right, and the numbers were minimal.
Yeah.
What I have a problem with is the thought process that your life isn't worth $500. Okay, so a person has a bad, has a concerning screening. They're not gonna have the hand up for $500 that day. Get the screening. I don't understand the thought process. I'm not saying I haven't got the money. You've gotta have the money. Get the thing and we'll figure money out later. I just,
So,
that's where I'm coming from.
and I will say, Art, you are just like my husband, who will pay anything for any screening at any point because he's had cancer, right? So he doesn't care. He will bankrupt us if it means.
Yeah.
But there are thousands of people in Vermont and millions across the country where medical debt is a stressor. It causes them poor health. They really don't have the money.
But true medical debt, this is up to $1,000.
For some people, $1,000,
But it's not payable that day.
it doesn't matter, Art. It's like, think about, and I don't disagree with you, but I do put myself in other people's shoes where they are a single mom with 2 kids. They really don't have the money. They don't have support. This is a decision, and I get it. You and I would make that decision. I get it.
Yeah.
But there's a reason we have medical debt for as little as $200.
And some of the screenings have to be done annually. So like, if you're a person with dense breast tissue and an ultrasound and a mammogram don't work, you could be looking at an MRI that costs over $1,200 every year, or you're foregoing it. So it's not just a one-time expense. It's and for some people, that amount of money every year.
And those people are typically on Medicaid maybe, and that covers.
Or on a.
Or not.
plan,
If you're on
or.
Medicaid, it's a whole other land.
Yeah, I'm thinking more of the HQPs.
All right.
HQPs.
I mean,
I'll take your word for it. I mean, I understand that people are poor and then that's an issue. But it's just, what if we put a number figure in there to cap it? Anything over $500 will cover. Anything over $400 will cover. Thought process.
Yeah.
It's just something that we could do.
oh, did someone else have something? Was someone else's hand up before she gets talking? I feel like she needs to ask, may I talk for a third time?
Oh,
May I leave on the committee in order to speak for a third time?
Opening language.
Yes.
No, I will talk to Jen about that.
Yeah.
Just for that screening part.
Yeah.
No, I wanted to just say to both Leslie and you, in your scenario about identifying if something's wrong. That's good patient care. That's bad coding.
Well, coding is your problem.
Yeah, well, what I'm saying is, that doesn't need to be, if you schedule a screening mammogram and they give you a piece of paper, because they give you a piece of paper and you fill out, and they ask you, have you had any of this or this? Just because you put that on there doesn't turn it into a diagnostic. They don't need to code it as diagnostic. It can be coded as primary screening.
But when you
and then
see that
things.
sign,
When you see that sign.
you are not,
And.
I mean, a lot of people do, but like
You're right,
that's.
and maybe we need to do some more education.
I was just going to say, because someone mentioned education, because does it mean a change in coding by who's coding it, the radiologist or the primary care person? And if it's the radiologist, that's a whole different land than if it's a primary care provider.
I don't think radiologists.
Well, they're submitting the bill. Right from the mammogram.
But the diagnosis on it, I mean, and you can have 12 diagnoses on it. And if the primary one is screening, then that's
But it's not very likely that someone's gonna code it as screening if someone has a mass in their left breast.
So,
But it could be, and it could be a cyst. I mean, we have no idea.
so we're not gonna solve the coding issue here. We are determining whether or not the intent of this bill is what we agree to or not. All we need is a majority to go one way or the other. Alan?
Should we cover every scenario that comes up in there?
No, we cannot.
So
Correct.
what we've done is pretty good.
Yes, Right.
Is it 100%? Maybe not.
right. But it's affording the opportunity for a small group of people to get the screening they need at a no cost share. All right.
Do we know, and I asked this, and I already figured the answer, but do we know how many cancer screenings we do waive or pay for or allow for no cost?
Cancer in general or breast
Yeah,
cancer?
cancer.
General?
Yeah, how many do we,
Oh,
because we've had we've
for
got,
screenings, so we have colonoscopy, we have breast cancer,
PSAs, prostate,
prostate cancer.
low dose lung CTs for
Okay.
lung cancer.
we're covering
You could do
the
a screening
big,
skin.
the big hitters
scan
here
for
as far as
melanoma.
cancer.
Yeah, we do depends on the plan. Dermatology,
Oh,
not as
yeah,
much.
yeah.
Primary care person, like.
Yeah,
Okay,
so there's more than just these two. But
okay,
it's not
that's good to
it's
know.
not
See, I
everybody.
didn't know about the prostate
Yeah.
screening, because that affects me certainly.
Yeah,
Oh, so does the melanoma. I mean,
Right.
people are
Melanoma
looking
affects
at
me
you.
too.
You know, when you're examined, you may not even know you're being screened in some ways.
Yeah,
Melanie?
So I was also curious if what we thought about doing in this, what Emily had recommended for linking it to the task force like we did with the colorectal.
Yes, we have to do that
Okay.
because
So-
otherwise the state has to pay.
Great,
So
so we
that-
have to do that. Yes. Okay.
That is a definite.
Yeah.
Super.
That
That was my
Good question. I don't
Yeah.
even know if it can be answered.
Okay.
This sign that you see when you go in.
Mhm.
What happens if you don't say anything? And you're in there and you're going through it, and then the doctor says to you, hey, by the way, have you noticed anything when you're taking a shower or anything? And you tell the doctor then, does that make a difference in terms of whether it's screening?
It's gonna be diagnostic, right?
I don't know.
It'll be
I think
diagnostic.
it's-
Would be the same.
I don't think we can answer that. I think it's gonna depend on how the doctor puts it. We can guess, right? We can sit around here. But
I mean,
don't think
I
we
don't
can
know.
answer that.
But
It sounds like
solves
it's
the problem. That's-
Not- If you have if you have an issue. Anyway, whatever.
Like, can't we get to the point where if a doctor says, I am gonna screen you for this, and then that's it? And then they put the code down. Then we don't have to worry about
we
it.
just tried to figure out.
Okay, we
This is
do.
a very
Why
small.
don't we put that in the bill?
Because it's not,
If only all was just covered.
it's just not that, it's like,
I was gonna work on that bill.
Topper, I wish it was that easy. I really do. I think this is getting us closer.
This conversation should be broadcast.
Wait, it is.
Broader. I mean, this is the crux of
So,
it.
Melissa?
Would you like to know, under the ACA, what
Affordable Care
cancer,
Act.
the Affordable Care Act, what cancer screenings are covered at 100%?
Yes.
Cervical cancer,
We didn't think about that.
prostate cancer screening, colorectal cancer screening, lung cancer screening, breast cancer screening, and that's it for cancers.
What about
What
brain?
was the last one, Melissa?
Don't get screened.
So this is screening. So breast
Breast
cancer
cancer.
screening, which is if you,
Yeah.
but then if you get a call
I didn't
back.
hear it.
Okay, sorry, that's what, yeah.
So we haven't included pap smears. Is it already in there somewhere?
That's cervical.
That's cervical.
I know, but we haven't included any bill.
We're not going there. We're
Yeah,
sticking to
we're-
this one because we're having trouble with this one. Sorry.
With that in mind, what diagnostic testing have we paid for cancer? Any other than this?
I don't know the answer to
That's a
that.
good question.
Well, technically kind of colorectal because we've made it so if you have an abnormal or an
Yeah.
inconclusive
Well,
result,
wait,
Yeah.
that you then can have further colonoscopy. But I don't think
Any other?
any other,
All right, I mean, I just, you know, it's, where does it end, I guess, is my thought process, but I get it, I get why, believe me.
So let me ask this question. In order for people to make a decision, is there more testimony you need to hear?
No.
Really.
it's like
I wouldn't mind,
an estimated cost.
Okay, I mean, we won't take a vote until we get, if we know whether or not we're gonna get an estimated cost.
right, that's the only thing I'd love to hear.
But do we,
about that.
you were really worried that the estimated cost might not be reliable. So we can get a number, which is gonna take us down a road that may be meaningless.
But we
I'm
can
worried
we
about
can get the
that.
number and then we can make the decision. I think we can also look at the testimony that was given earlier on the range for other states and the fact that New Hampshire did this.
Okay.
Yeah, and then it was minuscule.
And then it was what?
Small.
The
Minuscule,
cost
Yeah.
versus the benefit.
Yeah.
Okay.
and they can't find out any cost of benefit. They can't quantify that at all.
I guess I wasn't part here earlier, but I would say in general that if we can address cancer sooner, isn't that benefit worth any cost?
Well, here's my problem, not with this, because I don't see a personal choice factor having an influence on breast cancer. But for like lung cancer, I don't want to pay for someone else's smoking habit, all right? That's just me, all right? If you get lung cancer and you're a smoker, that's up to you, not me. That's my only thing, and so I totally understand this and, you know, right now, unless I hear something different.
What if,
Okay, we're not countering what he just said. That's his opinion, that he's,
well, I wasn't countering, it was a question.
nope, we are not doing that.
Okay,
That is his opinion. He stated it. We're moving
can
on.
I'll state an opinion then.
You can state your own opinion.
I would support treatment for any health condition because we never know what really caused it.
Great. So I think at this point, what we're gonna do is have Jen do the language changes that were in front of us. You'll get with Jen. We'll wait to hear from Sarah, and we will put this on the calendar for a vote on Friday. Does that work? Or tomorrow if we get back from Sarah. Okay. So this means that we are not starting tomorrow till 11. Is that exciting?
Sure.
Oh,
Well, considering we're gonna be here till 11 tonight.
Yeah, we're not.
You're not here till 11?
Yeah, actually, let's plan to be here tomorrow at 10:30 in case we can get Jen earlier to get through some of this stuff. We'll vote on, right, because we don't have anything right now before 11. So right now at 11, it's on the schedule to do the Medicaid expansion bill with a vote. Let's plan to be here around 10:30.
Okay.
So that if Jen is available, great, and if not, we'll start right at 11. And also I might see if she's available at 10:30 and we can do the colorectal bill. And then we'll put this on for Friday to give the Press Blue Shield time to get back to us. Does that seem to work for everyone? Okay, so 10:30 tomorrow. Thank you everyone for today. And it's gonna be a long day on the floor, so potentially today and tomorrow.
well, there's eight of them.
Take care of yourself.